we'd like to invite our next speaker to the stage, who will speak more on why FLS is important to all parties, why is the evidence base, and why we have to work and capture each fracture first and make sure we treat that well based on the evidence. Now, Professor Kassim Javaid doesn't need a huge introduction, but he's a clinical lead for the FLS DB at the Royal College of Physicians, London. Welcome, and thank you.
Very kind introduction. It's a real pleasure to be back here, and I hope we're not going to get any more political fireworks today, and it'll be a straightforward meeting for you all. So my name's Kassim Javaid. I'm a rheumatologist in Oxford, and here are my declarations. And Inder set me a very simple task. He said, why should we have an FLS this year, and how do we get there? So I'll just set the scene for you all. As you know, that when people break a bone, it does indicate that over half of them have osteoporosis. And if you do nothing, their bones will get worse, and they'll have more fractures with catastrophic results. And the fracture liaison service model is really there to capture those patients, to make sure they get nice approved treatments to reduce their risk of another fracture. So what is a fracture liaison service? It's a very simple model. You have to find them, assess them, recommend treatment, and then make sure they start and stay on treatment. And it's for most patients. It's not for complex patients who have to see clever doctors in hospitals. It's for patients who fall over, break their shoulder, don't have any other problems, and just need to be flagged with osteoporosis and get onto treatment. So why now? Why 2024? The first FLS was set up by the team in Glasgow in the 1990s, so why now? Well, as the Minister pointed out, we're all in trouble. The NHS has very little money. We're really focusing on prevention to reduce demand. And this graph shows you bed day admissions for a region of the UK, and each bar is a different diagnosis. Okay? So this is for all adults coming into hospital through the accident and emergency. So where do you think the number 1, number 2, and number 3 diagnoses are? Okay, hip fractures number 3, other fractures at the bottom as well. But this is incomplete. What this graph should say is this. Osteoporosis is number 3, and actually half of those other fractures are also osteoporosis. And it's by putting the burden of osteoporosis in context with other long-term conditions, it's what's driving policy change, both in Wales and across the world. And when you have these figures, you can then start doing some maths, and the numbers are frightening. The investment that the NHS has already given for osteoporosis care is almost 20 million. But how much are we spending on prevention? And it's this making visible the invisible burden that's changed the field. But this is a really golden opportunity, because when you look at the reversibility, it's actually very competitive. What do I mean by that? So this is data from Japan. Why do people go into care homes? Another massive burden for social and healthcare systems. So number 1, dementia, number 2, stroke, and fractures, third commonest reason for people going into care home. On the y-axis is how much does secondary prevention reduce healthcare spend and admissions. Stroke and blood pressure, no-brainer. If you've had a stroke, get the blood pressure under control, you'll reduce readmissions. But look how reversible and impactful fracture care is. It is a very effective secondary fracture prevention strategy. And secondary fracture prevention works. If you look at cardiovascular risk, the risk of another heart attack is very similar to the risk of another fracture after the first fracture. And we have secondary prevention after a heart attack around 96%. So why would we accept 80% failure after a fracture? It just doesn't make sense. So the NHS is actively looking for solutions. And we now have some new data to show actually the FLS is going to be even more impactful. The first new observation is when you have one fracture, the second fracture happens quickly. And we call this the imminent fracture risk. So this is data from Iceland. If you look at people who have a fracture and then say, of those people who have a fracture and refracture, how many of those refractures are happening within a few years? Well, after hip, humerus, and spine fracture, half of all those refractures happen in the first 2 years, and 80% happen within 5 years. So we have to act fast. Where are those refractures happening? They're happening in what we call non-spine sites. These are hip fractures. These are really devastating fractures. So we need treatments that can address that. And as you all know and you see in your wards, hip fractures and non-hip fractures have a significant effect. I don't want to focus on the mortality. Maybe 20% pass away in 1 year. But that means 80% are living with permanent disability and also risk of further fractures. And that's the real impact and burden of fractures. Now we know that just giving calcium and vitamin D, despite what it might say on the internet, has no impact on refracture rate. So if you see someone with a fracture and you think, well, at least I've given them calcium and vitamin D, you are not influencing their risk of another fracture. As you are aware, we've had a revolution in our treatments for osteoporosis. The NOG guidelines have shown this. We now have a range of treatments we can give to patients depending on their risk of fracture. But this also highlights an important step for how we get to that effective reduction in fractures that Inda talked about. We now know that to work in that imminent fracture risk period, we need treatments that reduce the risk of fractures very quickly. And oral bisphosphonates, even intravenous bisphosphonates, are taking too long to work. And that is why NICE recommendations have come out to address this. We wanted to make that real. What does it mean? What's the impact of treatment recommendation choice on future fracture risk? So working with health economists, we took 1,000 women who'd broken their shoulder after a fall and had a T-score of -2.9. Put them in a computer simulation. We worked out what their risk of another fracture is, knowing there's that blip in fracture risk. We worked out how long it takes the treatment to work, and we worked out how much the reduction in fractures were. Now, most of you in the room, when you saw this woman, would have given her a Lendronate, which is a very common anti-osteoporosis treatment. And you probably spent 10 minutes telling her about first thing in the morning, large glass of water, stay upright, might cause a bit of indigestion, all of that education. What was the impact of all of that education on reducing the risk of refracture? Do you think reduced refractures by 80%, maybe 60%, or 50%? Have a number in your mind how much you think that reduction in refracture is. From our modeling, the reduction in refracture is less than 20% because it simply takes too long for treatments to work. So if you want FLSs to be effective, you've got to be making sure they get on the right treatment. And on the other side, once you start the treatment, you have to work very hard to make sure they stay on treatment because the awareness of osteoporosis and its treatment is very low in patients and it's very low in the community. They may see you in the hospital for half an hour, but the rest of the years they're under the care of their primary care team. And that's where another challenge is. Now, Inda asked me a question. How would you measure good implementation of FLS in Wales? Well, clearly, fewer fractures. That should be the best measure of success. But that is tricky, and I want to explain that to you in the next 5 minutes. So this is data from the NHFD, and you times the number of hip fractures by 5 in Wales to give you the estimated total number of fracture patients. You can see from 2015 to 2023 what the data is, and then I've just estimated how much it will grow. It's just over 3% when you take out the effect of COVID. So if this is the estimated increase in fractures, what do we expect for FLS? What number are we aiming to achieve? And in which group? It may surprise the minister, but it's actually very hard to measure all fractures. They go through A&E, they're not coded properly, and actually hip fractures are our best count, but they're only 20% of all fractures, a relatively small number, and therefore you might have smaller signal to noise. Are we aiming to have fewer fractures? That's quite ambitious. Are we aiming to stabilize fractures? Actually, let's try and stop the age-related increase. Or are we just having a less steep increase? Actually, that is the wrong question. The number of fractures we have is going to be dependent on so many factors beyond age, comorbidities, and other risk factors. And that led me to think, what does implementation of FLS really have to prove? Do we have to prove that fracture rates go down? Because when you look at the literature, we have had tens of thousands of women and men go into clinical trials, and this is data from almost 30 years ago, and each time you give someone at high risk of fracture the drug, fracture risk goes down. We now have data outside of trials. This is data from England looking at people who've had a hip fracture, and then look what happened when one of the drugs became very cheap and widely available. You can see here the prescribing rate went up, and at the community level, the fracture rate went down. So all the evidence shows that actually if you give high-risk patients an anti-osteoporosis drug, fracture risk goes down. So Inda, I will say it is not about effectiveness, it's implementation. The question isn't does it reduce fractures, but can you get the right treatment to the right patient? And that is very important for FLSs because they work in a system where FLS is almost bound to fail. Why do I say that quite controversial statement? It's a nightmare. A patient with a fracture comes in, they'll go to A&E, they'll have an X-ray, they might go and see an orthogeriatrician, they might go to the trauma ward, they might go to the general ward. How are you going to find them? They might actually go back home. They might go into the community, they might go into rehabilitation. They get lost very easily. Services are changing, it gets very complicated. So actually, FLSs have many challenges to implementation after they've started. Have they found the right patients? Are they doing the complete assessment? Are they recommending the treatment according to fracture risk? And are they monitoring the patient? And that is your challenge for Wales, setting up the services and making sure they reach their target population. But you are not alone. We have fantastic resources from the ROS, we have the clinical standards, and from the FLSDB, we have a roadmap. Every person in Wales, from day 1 to day 365, those green circles tell them what they should be receiving. And everyone who has a fracture should know that. What you should have had by 12 weeks, 16 weeks, and 1 year. Because they don't know. They come in, they break their shoulder, they have no idea what's expected to happen afterwards. And that is unfair. What have we done? We're working with the FLSDB. We've created key performance indicators. These are checkpoints to show how well each part of the pathway is working. And I like to use this analogy because I often get asked, why do you have so many KPIs? It's really hard to record. Who here cycles? Anyone here cycle? Which part of your bicycle do you not look after? Yeah, the whole thing has to work, otherwise nothing works. And that's why the KPIs are there. You have to have this whole system approach. And it's only when you achieve that whole system approach, you'll give what the minister wants, which is the maximum avoided fractures. You find the high-risk patients, you find the ones who are going to refracture quickly, and you look at the treatment benefit from the treatments you offer and make sure they stay on treatments. So this then changes the argument, what dose of FLS do you want Welsh patients to see? How good a service do you want? And from our modelling, the best sort of minimum standard is 80% of your patients get identified, well over half get treated, but critically, you do all that work, make sure the ones you recommend treatment start and stay on treatment. And we can now achieve that. And when you do that, the benefits are significant. You put an FLS in Wales, across every hospital, you start seeing 22,000 patients. These are the number of fractures you avoid, and this is the work through the Royal Osteoporosis Benefits Calculator. It's a step change in independence, families' lives, patients' lives. So how do you get there? Well, this is how the Fracture Liaison Service database works in my head. We have very busy clinical teams who preferably upload or directly enter their data to the Royal College of Physicians, and we give that data back to the hospitals and also to decision makers. But the only purpose of the data from my perspective is relentless service improvement. You set up a service, unless you're undertaking relentless service improvement, you won't go from red and amber to green across every hospital in Wales, which is your aim. So service improvement is actually what you need to show as your outcome for FLS in Wales. Not fracture rates, not other KPIs. It's how many service improvement cycles you've got. And we know how to do this. We're not the only clinical specialty doing service improvement. There are tools. There are driver diagrams, fishbone diagrams, smart aims. There are standard tools you can use in your FLS that will use data to improve your service. But have we fully utilized them? Does every person in the FLS team know how to conduct effective service improvement? Do they have time in their rota to deliver service improvement? Do they have the influence to change their pathways? Sometimes they have great ideas, but they don't have the influence in their organization to change things. And then how many cycles are they doing a year? Are we measuring that? So just on the other risks you might want to think about, Inda. Obviously, there are workforce issues, there's training issues, maybe low patient numbers. But another model you can consider is, do you need an FLS in every hospital? FLSs are now generally turning telemed. COVID has taught us that telemed FLS does not reduce monitoring, does not reduce adherence. It stays the same. And we now have systems where one FLS covers multiple hospitals. And the benefit of this is you can have a clinical lead who will now be managing multiple sites, because actually boneheads are actually quite uncommon, and they can have, that can slow down a service. The second key issue is digital. Who here has an electronic system in their hospital that works amazingly and saves them time? You should not be laughing, because your NHS government is paying millions to give you that digital system. That should not be a laugh. You should be demanding it. So think about this. How do you see more patients with the same staff? Well, you reduce the admin burden. That will immediately liberate a third more capacity, probably more. And if you have a very good digital solution, maybe across the whole of Wales, to set up a Welsh FLS digital management system, they'll be able to identify the patients easily, they'll be able to assess them using the same forms, you can auto-template the letters, they go to the GP, and a special one goes to the patient and the carer. You can automate monitoring, so the FLS knows who needs to be monitored, does the forms and the letters. It can check who's missing, who didn't turn up to their appointment, who hasn't had their monitoring visit. All of these things can drastically cut down the administrative workload and increase productivity. So make sure you have a digital solution for your FLS implementation. And embrace new technologies. So there are now AI models out there. There are a growing number. AI is going to happen. We're working with a team in Cardiff to test one in their hospital. And it's a very simple problem statement. 20,000, 30,000, 50,000 CT scans every year in your region. 10% of those were vertebral fractures. Less than half the radiologists will comment on them. Less than 5% anything happens. You've immediately got thousands of patients with spine fractures which are very dangerous who are being missed. Rather than pay a radiologist to go through them again, just use AI. The AI will flag them and manage them. Finally, if you're going to do something like this, you need to have leadership. Leadership is not something that is innate. It is something you can learn how to do. So we need to make sure that these FLS champions have the leadership support and training to deliver. They should be reading the literature from other organizations with good leadership. We need to have very good project management. This is a very complicated project. You have radiology, orthopedics, internal medicine, community care, primary care, pharmacy, lab sciences, everyone with their own agenda. How do you roll out something so complex? Requires project management skills. So make sure when you implement your FLS, you've got dedicated project managers to deliver this, who know how to run agile cycles and sprints, who know how to monitor people with Kanban boards. And then have an overview. You'll have hospitals at different stages of evolution. You've got some fantastic FLSs, and you've got hospitals with nothing. They're all part of the mix of getting started and becoming improved. Bring them together. Work out for each 6 months what their individual hospital goals are that are realistic and achievable. And that way you can structure the delivery over time. It leverages expertise between FLSs. you get KPIs driving improvement, and you get efficiencies, sharing digital or even sharing workforces. And this can really be summarized by this, where you can have each hospital as a row, and you can just report back on how they've been improving over time. There's lots of help on hand. You've got the ROS with their fantastic FLS implementation toolkit. We've got our own toolkits on the FLSDB. There are European networks. There are meetings you can go to as well. So I'd like to close by saying I'm just a tiny cog in a huge team. I just stand up and talk, but the real work happens with others, especially with Oxford and the Royal College of Physicians, and leave you with this thought. Thank you very much.
Thank you, Kassim. We appreciate your partnership and support for the NHS Wales, and where we pledge to continue to deliver and develop the very high quality FLS services, and we'll achieve that.